Welcome to the BioBalance Healthcast, episode 677. Dr. Maupin's lecture to other doctors. Why women need testosterone.
BioBalance Healthcast features conversations about anti-aging medicine. Your host is Dr. Kathy Maupin, Medical Director of BioBalance Health and a leading expert in treating symptoms of aging. Dr. Maupin is the author of The SECRET Female Hormone, the seminal work about testosterone replacement therapy for women, and Got Testosterone, the award-winning book for men that helps men choose the most effective and safe form of testosterone replacement. These books are available on Amazon or from Dr. Maupin's office at BioBalance Health in St. Louis and in Kansas City. Dr. Maupin's office is currently accepting new patients.
Today I want to talk about the importance of testosterone for women. And I have to tell you, I learned this firsthand. I had my ovaries out because of endometriosis, and that was back in 2002. And it was a devastating thing, because when I woke up, I wasn't myself. And that had a lot to do with not having any hormones at all, but I was considered the hormone queen in St. Louis. I had been doing bioidentical hormones since 1986, and everybody sent their problems to me. So I wake up and I have terrible problems with even getting out of bed, no motivation. I gained 20 pounds in a month. I didn't think the same. My mental capacity was bad. So I have gone to everyone in our area, and they called me lazy, fat, crazy. I was sent to psychiatrists, and now I have patients that tell me the same thing, the same rigmarole. I didn't find anybody who was doing testosterone treatment or even estrogen in a bioidentical fashion that worked back in 2002. So by God's grace, I met Gino Tutera, who's Mr. Sotopelle now, or Dr. Sotopelle now. But then he was just Dr. Tutera. And he treated me. And I was better so fast. But people without ovaries feel better really fast because they are miserable. So I slept for the first time in years that first night of after having the pellets, and I thought it was going to be, that must be placebo effect, but I've been sleeping ever since. And before that, I had terrible migraines. I couldn't go to work. They carried me out. Every week, I'd go out a couple times. They'd have to cancel patients. That's a horrible thing for a physician, and I was on call as well then. So basically, Gino Tutera saved me by giving me testosterone and estradiol pellets, and then I asked him to train me. And that was the beginning of what I do now. I slowly brought my practice away from OBGYN and into age management medicine. And that has happened over the last 12 years, and I am so happy. I have the best life. If you do this and you have women come in and tell you how wonderful your therapy is every day, it's almost as good as delivering babies, but you don't have to get up at night. So I'm trying to encourage you to do this. So this just gives you my credentials, and this is on your computer, whatever you downloaded. Okay, so for all of those of you who are obsessive compulsive, I'm sure there's nobody like that in here. This is what we're going to talk about. We're going to talk about testosterone deficiency, what it is, what the long-term effects are, the physiology of testosterone in women, but that's going to be very brief because I've got lots to talk about. How to diagnose testosterone and low testosterone in women. Comparison of the different delivery systems like transdermal versus vaginal versus pellet therapy. Ideal dosage, what blood labs you should get, what levels you should look at. Troubleshooting, which is the biggest part of this, is how do we take a patient who has an unusual side effect or an unusual to us, and how do we fix that? So troubleshooting is key to being a good bioidentical testosterone pellet therapist for patients. And even with creams and gels, it's the same issue. And then my benediction, which is I learned how to speak in church, so which may or may not be good for you guys. So let me go back one. This is a new toy for me. So this is basically what my patients look like. Their face is on my desk. This is a dinner table. But their face is on my desk. They're exhausted. They can't even hold their heads up when they come in, when they have true testosterone deficiency. This patient was it that we're going to speak about to give you kind of a notion of what kind of patient I see. Professional woman, 47 years old. She had her ovaries out like I did. Her symptoms began immediately after surgery, which made her very angry about having a hysterectomy. But people need hysterectomies and they need their ovaries out. And so it wasn't about the hysterectomy, it was about what happened after. So she did the same thing as I did. She sought all kinds of different opinions, and everyone was very unfriendly to her, thought she was just lying, which is, I guess, what we do if we don't know what to do next. So she saw every specialty. But this is what she looked like. She looked exhausted. She was round, and she showed me a picture of herself like you would at a plastic surgeon. Here's what I used to look like, she said. This doesn't look like me anymore. She had fat on the back of her neck like Cushing's. She was pale. All of her skin was sagging, kind of like she had no blood flow to her face. Basically, if you don't have testosterone, you divert all of your blood flow to the internal organs because you're old, you must be old, and you must not need blood flow to your face. So that's why people look old when they don't have testosterone. She was swollen, she was puffy around the eyes and the fingers, things you can just look at when patients have their clothes on. So these were the symptoms that she gave me, and these are common. These are so common that when you see this group of symptoms, you have to first think testosterone deficiency before you think of anything else. All of these were new onsets since she had her hysterectomy. She had a few of them to begin with because she was 47, like her sleep wasn't great before, but now it was terrible. She also complained of hot flashes because no one would give her estrogen because everybody was so afraid of giving somebody estrogen that they might have a blood clot or something. They hadn't read all the articles about giving estrogen in a non-oral fashion that causes you not to have a blood clot, and bioidenticals are, of course, less risk as well. But she had all of these symptoms. She had gone to some of the doctors and gotten bioidentical estrogen. That's great, but it didn't work for her. Bioidentical progesterone, all those different types, that didn't work. And she didn't take them all at once. She took them in series instead of in parallel. Somebody gave her diet pills, made her a tiny bit better. She didn't lose an ounce. And antidepressants made her a little happier. Her sleep was terrible still on Ambien. But when we gave her testosterone, and this is what I treated her with, she came back and said, I got my life back. I am so much better. In 3 months, she came back with her new lab. I do lab tests beforehand. I do lab tests at 3-month mark, and then I see my patients. She had 1 pellet of pure testosterone and 1 pellet of testosterone and Arimidex because her estrone was very high. So I didn't want, estrone is made, I'll show you later, but it's made in the, made by conversion from testosterone, made in the fat and made in the adrenal gland. And when testosterone goes down, estrone goes up. So her testosterone had been low, so I was trying to help her get her weight back in action. So I gave her 90 milligrams of testosterone and 10 of Arimidex, which is much lower than the oral dose of 1 milligram a day of Arimidex, divided by 120. Oh, 100 of testosterone and 90. 1 pellet is 100, the other one was 90, plus the 10 of Arimidex. It's mixed together. So she had 190 of testosterone. That's not unusual in pellets, and it's not, but I was trying to get her out of her depression and all these other symptoms. I would probably lower it the next round, but I don't usually go below 175. Okay, so she had resolution of all of her symptoms. So what we're trying to do here, if you think about it, is resolve symptoms. We're not trying to get a number. We make the same mistake with thyroid. We're always trying to hit a number. We're not trying to treat the patient. So here, you're trying to treat the patient. So you look at all of her symptoms, and you follow them. You follow lab, but more, the lab is really not about comparing her to other people, but comparing her to herself. You can look at her estrone level. You can look at her estradiol level. You can also look at her testosterone level. But if she feels good, that's where you find that's her perfect level. It's all individualized. And we're trying to hit that perfect place where she feels really good and then stay there. So she had a weight loss. She was 5'4", weighed 130 when it was over. So that's awesome. But she had improved muscle mass. So what I tell people is, Don't weigh yourself every day. You measure your waist once a week, once a month, whatever's comfortable with you, because that's where you're going to start losing weight. You gain muscle. So at first you don't lose anything, but you get smaller, get more compact. So when I'm diagnosing testosterone deficiency, I don't look just at lab or just at symptoms. I look at all of them. I look at the interview. I ask all the questions that are necessary to ask somebody who's miserable. Not just do you sleep, but do you have the kind of sleep disturbance that people with testosterone deficiency have, which is I go to sleep because I'm exhausted. I wake up at 2 o'clock, which everybody thinks is depression, which isn't always depression. I wake up at 2 o'clock, I wander around, I can't do anything productive. I go back to sleep and I wake up tired. That's a terrible night's sleep, and that is getting you nowhere in terms of feeling good the next day. So non-restful sleep is very common when people have low testosterone. So I go through interview and I go through the complete medical history, past medical history, which will tell me a lot about head injuries. As you know, head injuries can decrease. I mean, if somebody didn't have a hysterectomy, I'm looking for a reason why, if they're young, why they have a low testosterone. So head injury is one of the reasons. For these women, I look at their past GYN history, if they've had ovaries removed, and if they've had endometriosis and still have ovaries. Oftentimes, I'm looking to see if that's the case, because I've found, and this is not in any study, so just wipe this off your brain after I say it, but many more women in my practice that have had endometriosis have low testosterone. Now, I don't know, I haven't found a study that backs that, but that's just what I've noticed. So we're going to go over the lab values later, but why testosterone is important for women? Well, it is there's 3 times as much testosterone in women as estradiol, and this is from, it's in several studies, but I quoted it from Carolyn Bondi, and this is her, I got permission to use her graph. Testosterone is there above the estradiol, and that is testosterone level, estradiol level through the years as people go through from birth to 62. So you can see that that's true. So then why do they say it's not a woman's hormone? I guess it's simplification. It makes it easier to say men are from Mars, women are from Venus, men have testosterone, women have estradiol. I'm not sure, but it's causing a lot of trouble for us getting testosterone and actually having insurance reimbursement if they won't acknowledge that it's our hormone. That's one of the studies that I send to insurance companies. So testosterone's role is much the same as men's. If you think of what men get out of testosterone, we get the same stuff too, but we don't have commercials. Nobody's out there pitching it for us, but we get the same stuff. I mean, we get great muscle and bone. We get a waistline back. I mean, guys do too. But we get our energy, our motivation. And remember that memory part? Any women in here who have not replaced your testosterone yet, but when you can't remember the label for something like that great restaurant, that best friend down the street number of your daughter, I mean, when you can't remember a label, that's low testosterone. And that is one of the things I ask people specifically to see if I really need to look at them closely and if I need to give them more or if I need to actually decide that I have to look at something else to take care of their symptoms. But you can see all of these. That's the role in women and men. The mechanism of action depends on the tissue. Depends on the androgen receptor, and it depends on how it turns the tissue on. So the mechanism of action is anabolic activity. We know that. Everybody who's female knows that we make more muscle when we have our testosterone, and as we get older, we don't have as defined muscles, and we get more fat in the muscles, like marbling in a steak. It's lovely. Then it's a vasodilator, so that's why it helps men have erections and helps us prepare for sex by swelling. It's an immune stimulator, which is great because as we get older, our immune system tanks. And so this is something to help your immune system come back. That's why we give testosterone to AIDS patients, because it stimulates their immune system so that they can fight cancers. It's not because we want to make them happy. It's because we are trying to make them not get yet another problem as a cancer. So for us, aging, our immune system's going down. Why don't we bump it up a little bit? And this is one of the good things testosterone does for us. Bone growth. All these drugs that we have for bones, it's not making good bone. We've had lots of lectures about this in the past. Give testosterone instead of all of those medicines. They're expensive. They don't make strong bone. They make brittle bone. And people still break their hip. It's useless. It looks great on x-ray. That's it. So we're treating the x-ray. So instead, if you replace testosterone and or estrogen in women, you can build great bone. And that's much more important than saying, oh yeah, I gave this woman Fosamax to your drug rep. Endocrine stimulator, that's a thing that what I'm referring to there is that testosterone stimulates other glands to make other hormones like growth hormone. Growth hormone stimulated by testosterone. I always see growth hormone go up after I give testosterone. So I tell my patients, this is a twofer. You're getting growth hormone because you're testosterone stimulating it. And it's safe. It doesn't cause diabetes that way. It doesn't cause other diseases that way. So testosterone also protects women from these diseases. It makes you less insulin resistant. We talked about bones. It actually decreases cholesterol. It decreases inflammation, so it decreases heart disease and stroke. Fibromyalgia, that's amazing. These fibromyalgia patients have nowhere to go. No one's taking care of them. And they're being given pain meds and things like that, but they're not better. So I give them testosterone. They always have low testosterone because they're usually older by the time they get to me. But even some of the young women have low testosterone. When I treat them with testosterone, they don't have pain anymore. It is miraculous, and they are so excited to be better. It's amazing. It's like that with other autoimmune disorders as well. I have one patient who has rheumatoid arthritis, and she's had it for 10 years, and she's sat in a chair looking at the wall for 10 years, and she's maxed out her drugs. So I treated her, and I said, I can't promise you anything because I don't know how far this has gone in your joints. And she came in, I didn't recognize her. She walked in my door, in my office, and said, hi, and I said, who? Wasn't the same person. It just wasn't. She said, I just painted the whole inside of my house. I am so well, and I take no other drugs but testosterone. Now, I don't expect everybody to get that, but that was a miracle, and that was just testosterone and a little bit of estrogen. It made all the difference. And there are lots of research articles in the rheumatology journals if you want to look. Just look at the keywords for autoimmune disorder and testosterone, and you'll find them. The others, you know, frailty. We've talked about that this week. Excuse me. Okay, testosterone and libido. The big thing, everybody talks about sex. They love to talk about sex. But my view on sex is that everybody deserves to have sex their whole life. It's not like you're 40 and it's over, which is what all the younger people think. Or, I mean, not all of them, but many young people think that. And they treat us like we're over the hill or we're grossing them out if we talk about wanting a libido. So testosterone's the libido queen, king, whatever you want to call it. And it is the key to libido. If there's no abuse, if there's no sexual abuse in the history of a patient, and they've always been okay with sex with this current partner, you give them testosterone, it's back. This is the key to this. And everybody acts like it's, barely works. I don't know what they're giving people, but they must not be giving them enough testosterone because it brings it back. And some of my patients who have always had low testosterone or have been on the birth control pill all the time, they get their orgasms they've never had. 30 years, they've never had an orgasm being married to the same guy. They come in and they go, I know what it is. This is awesome. Our marriage is so much better. I get flowers from their husbands, which is always nice.
Email your questions or comments to podcast@biobalancehealth.com. You can find the BioBalance Healthcast on iTunes and on YouTube. For more information about bioidentical hormone pellet therapy and other reverse aging solutions, visit biobalancehealth.com or call 314-993-0963. You can find Dr. Maupin on Twitter @Dr. Kathy Maupin and on Facebook at facebook.com/biobalancehealth.